I think that one of the most important things that we can do in a conversation with the patient is really frame it as a risk situation. Of course, no medications are without risk in pregnancy, and that's true of antidepressants as well. And I think that providers are really good about talking to patients about those risks. I think the part of the conversation that's equally important, though, is talking to patients about the risks of stopping their medications. And I think that this research really adds to that body of work. And I think emphasizes that there are really significant risks to patients of stopping their medications. And in this case, we saw that it significantly increased the risk of a behavioral health emergency for a patient, which is really, disruptive and potentially dangerous. Part of the reason for studying this too is that we know that suicide is one of the major contributors to maternal mortality in the United States, and that having untreated or undertreated depression and anxiety significantly increase the risk of suicide or suicidal ideation in patients. And so I think making sure that patients understand that this could destabilize their mental health in pregnancy if they're stopping medications. I think that's a good question. And, of course, this was looking at population data. So we're not able to, tease out the individual kind of reasons why patients had a mental health emergency and kind of what their trajectory of depression was. But we know that stopping medications is associated with significant increase of relapse of prior depression and anxiety. And here, our population was patients who had an underlying mental health diagnosis even prior to pregnancy. So I think it may be a combination of all three. But in any case, it certainly seems like stopping antidepressants for a large percentage of this population did mean that they had a rebound in depressive or anxiety symptoms that landed them in the emergency department. I think the other thing is that we don't know exactly why they had an emergency department visit. So it's hard to know, what percentage was for a suicide attempt or suicidal ideation. I still think that's probably not the majority of people, fortunately. But I think that if patients had enough symptoms of uncontrolled mental health that they had to go in an emergency department, that's really significant. And so I think that's really important for OBGYNs to consider when they're having these conversations and make sure that patients understand when they're making decisions about their medications in pregnancy. It's a good question, and we weren't specifically looking at this in the data, but certainly it has been shown that patients who are younger, patients of color, are more likely to have difficulty with control of symptoms in pregnancy. And one could argue that that probably is true in this population as well. We also know that, of course, depressive and anxiety symptoms don't occur in a vacuum. And certainly there are socioeconomic factors and social factors that patients may face that may impact their sort of risk of developing worsening symptoms in pregnancy, especially among patients who stop. I think the thing that we were focusing on here, which was interesting, is looking at the differences between patients who continued or discontinued their medications. And we did see that patients who stopped their medications were more likely to have their medications prescribed by a non-OBGYN. And that was a significant finding because it tells us that those are potentially the providers that we could target in terms of ensuring that they feel comfortable with counseling on this topic with patients and that they're providing consistent messaging. One of the things that I'm doing next with this research is I'm actually doing a mixed method study where I'm surveying both clinicians and patients about their experience in pregnancy making these decisions. And one thing that sort of come out of my conversation is that some patients, were prescribed their antidepressant by a really well-meaning primary care provider or psychiatrist, but may not have necessarily gotten counseling before they were pregnant about what to do with their medications. And suddenly the patient finds themselves pregnant and they're not sure what to do, right? And many patients unfortunately don't see an OBGYN until they're maybe like 9, 10 weeks of pregnancy. And in that interim, they're left in kind of a vacuum of, potentially no information or maybe misinformation and stop their medications. And so I think that this is potentially kind of a targetable point in time where we can make sure that patients are getting good, clear information about what to do and are making an informed choice, because ultimately that's really the most important thing. I think the first thing is always asking, right? So, I think we live in a time where fortunately there's a lot more focus on mental health. And I think that many practices have started to, implement ACOG's recommendations and screen all patients for depression and anxiety in the beginning of pregnancy. And I think that the next step is to really further these conversations with patients. Many times patients say, yes, I have a history of depression or anxiety. They're asked, are you on medications? And they may just say no. But really what they mean is that they were on medications and stopped them, and making sure that we really dig into that and understand what's the trajectory of patients' disease. Did they stop their medications? Why? Do they understand kind of the benefits and harms of doing that? It's a really time consuming conversation. And I think one of the, points I've gotten from talking to physicians about this is that they may not necessarily have the time in a really busy new OBGYN session to really dig into a patient's mental health history. And that's so understandable. But I think highlighting that this work really needs to be done. And these conversations are so critical to ensure that patients are, being cared for in the best way during pregnancy and postpartum. And I think one of the things that I'm hoping to do next is to use this information from this study and from my mixed methods studies of patients and providers, and really come up with ways that we can better inform patients and be able to help providers with these, difficult and potentially time-consuming conversations. And that may even be just communicating with the patient ahead of the visit in early pregnancy, and giving them information even before they've stepped foot into an OBGYN office.